Dobar dan, samo da vam kažem, sad ću ja da se prevlacim na engleski jezik, je to okej? Yes. Well, welcome to this special event, which is organized for you as students of Belgrade University, but also not only for you, but for all students who are members of academic community of even nine universities belonging to so-called Circle U network, academic network. If we are speaking which universities are those, besides our University of Belgrade, we would have here Paris University, Site University. After that, we will have University from Louvain, then University from Berlin, Humboldt University, Oslo, Aarhus, also King College London, and our new very welcome colleagues from universities of Pisa and University of Vienna. However, today we also have pleasure to have our already for many years colleagues with whom we are cooperating. So we have also one professor coming from Harvard Medical School, Division for Global Health. So about what we will speak today and discuss, because this event would not be good without your participation. Therefore, we expect that we will have interactions. For that interactions, you already see on the screen. Please click on this barcode and you will find yourself in the environment of Circle U University. To the topic of global health. I'm sure that you already have some idea what global health could be, but definitely that is study, research, and practice about priority health problems which are crossing over borders of many countries, and not only about health problems and how to solve them and improve, but also we may say that global health is a synthesis of public health sciences and clinical medicine, and despite global health is always looking as main focus to disease prevention, nevertheless it also embraces clinical services, also curative services, and the way how we can advance medical sciences as such. And you will see, you will enjoy, because we will start with the most important issue of today with our professor, colleague, and friend from Harvard University, who will make highlights how collaboration for global health can be something what is our pathway in searching for better health for all people of the world. So first, I would invite Professor Brett Nelson from Division for Global Health, and then gradually you will meet our professors on this amazing day. Thank you for coming.
Dobar dan, dame I gospodo, baš mi je drago da budem sa vama. It's a pleasure to be with you all. I'm excited to be part of the Circle U presentation. I appreciate all that Circle U and our hosts here in Serbia have done to invite us here and organize this. Today, I wanted to talk a little bit about the challenges that we all face when we're working in a global health setting, and also leave you with some potential solutions. So first, let me give you some examples of the challenges that we face. I'm only going to give a few examples because there are many when you're working at a resource-limited setting or when you're working in global health. So let me begin with maybe the most obvious problem that we face, that is of inadequate healthcare funding. Now, there are many parts of the world where a Ministry of Health has less than $50 to spend on healthcare for each of their citizens. Madagascar, for example, has only $20 per person. Serbia here, you have 650, last that I saw. Italy, nearly 3,000. Germany, 7,400. The US spends $13,000 per person per year on healthcare. And as an American, I have to, all that money does not necessarily mean we have better outcomes. In fact, we don't. So inadequate healthcare funding is an issue. Another challenge that we face is limited healthcare workforce. So in low and middle income countries, there's a shortage of 18 million healthcare providers. And this is particularly a problem in rural areas, outside capital cities. In low-income countries, there's only 0.5 physicians per 1,000 people. This is compared to 2.6 physicians per 1,000 people in high-income countries. So high-income countries have at least 5 times more healthcare workers than in low-income countries. And you might argue that we need those physicians and clinicians in the low-income countries even more desperately than we might need them in high-income countries. The third challenge I wanted to mention is the challenge of inadequate access to healthcare services. So over half the world's population does not have access to essential healthcare services. In conflict-affected countries, half of the healthcare facilities that do exist are either destroyed or inaccessible or damaged. So I know that was only 3 examples of the challenges, but there are many other challenges as well. We could talk about inadequate political will, cultural language barriers, insecurity, poverty, infectious diseases, et cetera, et cetera. But rather than go through all of those in any detail, I'd like to now show some examples of solutions. So the first potential solution for the challenges that we face in global health is cost-effective training. So for training to be cost-effective, it needs to be adapted to the local resources as well as to the available personnel. It needs to use affordable training equipment. I will give you some examples of that. It needs to use a training of trainer model. That means that you train a master trainer, hopefully a local champion, who then goes and trains their colleagues and so forth. And then ideally, your training should be integrated into the existing pre-service and in-service curriculum. What I mean there is that if you introduce a new a new training, ideally teach the medical students and teach the PA students and teach the nursing students and have it be part of their curriculum so it's more sustainable. Some examples of recently developed cost-effective training include the Helping Babies Survive program. Has anyone heard of the Helping Babies Survive program? So it was developed by the American Academy of Pediatrics, UNICEF, WHO, LDS Charities, and others. And it is teaching providers the essentials for taking care of babies after birth in those first minutes and then hours after birth. Helping Mothers Survive is a similar training curriculum. This one focuses on how to keep mothers safe during pregnancy and during and after delivery. The WHO has a fantastic curriculum called Essential Newborn Care that does similarly, and they have a curriculum called IMCI, or the Integrated Management of Childhood Illnesses. These are all very cost-effective training programs, and they use equipment like you see here. This is a cute little blow-up doll. She's called Neo Natalie, and she is very affordable. Instead of costing thousands of dollars, she costs about $50 to $60. This is a mannequin to simulate a pregnant mother, and you can practice delivering a baby. You can practice addressing postpartum hemorrhage and other issues related to maternal health. And all of these curricula come with illustrated algorithms that are color-coded and very simple and easy to follow. So that's one potential solution. The next two examples are low-cost devices. The first one I wanted to mention is low-cost bubble CPAP. So as you may know, respiratory conditions are one of the leading causes of mortality and morbidity in children and in newborns. And when I'm referring to things like pneumonia or respiratory distress as a result of sepsis or retained fluid in the lungs. All of these can be very, very harmful to a young child. Now, a ventilator that you might see in a tertiary hospital can cost anywhere from $25,000 US to $50,000 US dollars. Now, of course, this is going to be prohibitively expensive for many low and middle income countries. So the solution that we've proposed is to develop low-cost bubble CPAP. And that's illustrated here. You have some sort of air or oxygen source, whether it's a tank or an electric oxygen concentrator. And it's connected to some tubing that goes to the newborn and then goes into a bottle of water. Now, this can be a shampoo bottle or a Coca-Cola bottle or whatever you have. And the deeper you push the tube into the water, the more pressure that builds up in the circuit and the more pressured air that the baby gets. So it's a very simple approach to giving pressured support to newborns and children. And instead of costing $50,000, these can be made from local ingredients and cost less than $10. One last example is a condom-based uterine balloon. Just as background, postpartum hemorrhage or bleeding after delivery is the leading cause of maternal deaths worldwide. In fact, 27% of all maternal deaths in the world are a result of this bleeding or postpartum hemorrhage. Now, in high-income countries, those that can afford it, they might use a balloon called a Bakri balloon, but it costs up to $500. It's inserted into the bleeding uterus. It's blown up with water or IV fluids, and the pressure against the bleeding uterus stops the bleeding. But most countries can't afford $500 for a balloon. So we've been working on developing a balloon that uses a condom. So it's a condom-based uterine balloon. It's made of, again, ingredients that you can find at any clinic. So a syringe, a urinary catheter or IV tubing, and you tie a normal condom onto the end. And then you fill it with clean water, and it pushes against the walls of the bleeding uterus, and it stops the bleeding. And this device is very simple, very easy to use, and it costs less than $5. We did a study in 4 sub-Saharan African countries with this condom-based balloon amongst over 300 women that had uncontrolled postpartum hemorrhage. And we had 97% survival just with a condom-based balloon. So simple solutions for difficult challenges. So in conclusion, there are significant challenges working in global health and in resource-limited settings. We talked about funding, healthcare workers, and infrastructure, but there are many other problems. And then solutions are simple, low-cost solutions can be developed and can save many lives. We talked about low-cost training, bubble CPAP, and condom-based uterine balloon. I will end there. So thank you.
Thank you. Thank you, that was really amazing. You saw practical skills are very important, but also it's important that we can find very cheap solutions for very big problems of global health, as you saw. We do not need special equipment to save lives in the global world. Thank you, Brett. Later we will ask more questions, but now I would like that we pay attention to the biggest burden of the world, and those are cardiovascular diseases in global health, and how we can prevent, how we can bring world population to have good cardiovascular health. For that, we will have indeed really expert in the field, because this is our professor Jean-Philippe Empana, coming from Paris University side. He is INSERM research director, but even most important, he is our academic chair for global health of our Circle U University. So grab him after this event during the break and ask about opportunities, what is there for you, and how you can advance yourself on this way of global health, going, for example, to Paris and summer school which they are organizing. So please, Jean-Philippe, I will make your presentation, and we will listen about the burden of cardiovascular diseases and how to improve cardiovascular health.
Thank you, Vesna. Do you hear me? Yes? Okay. So before I start, I would like to thank again Vesna, Bojana, and Milos for their kind invitation. And it's my first time in Belgrade. I had the time to visit a bit the city, and I really enjoy it. So it's a great pleasure to be here, and I hope to come back. So in these 10 minutes, I will talk to you about a new concept of prevention. I know that as medical students, you are aware of prevention, but you will, I think you will learn a new way of thinking about prevention for cardiovascular disease, but you will see also that it's gone much beyond cardiovascular disease. And so you can imagine the public health impact of this strategy. So briefly, you all know probably what we call secondary prevention. We talk about patients that have already suffered from CVD, and here the aim is to prevent the recurrence of the event. You have learned this, or you will learn this in your coming years in your medical studies. You may be familiar also with what we call primary prevention. We talk about the general population, you and me. Some of us have 1 or 2 risk factors, and the plan is to control the level of blood pressure, or the control of your blood lipids, to avoid the appearance for the first time of CVD event. And with these 2 approaches, we have made great progress. You may know that CVD mortality has been declining, but still, as Vesna was saying, it's still the first killing worldwide, including in what we call low-income countries, which is challenging with what we call epidemiological transition, meaning that they move from infectious disease to chronic disease, unfortunately for them. And because of this, worldwide, CVD is the first killer. And meaning that we need to make new advances and to find new strategy to avoid the appearance of CVD events. And this is the purpose of this strategy, of this presentation about primordial prevention. And you see that there are 2 keywords, prevention of course, but also primordial, meaning that it's very important, but also it should appear very early on life. And the aim of this strategy is to avoid the appearance of the risk factors themselves in the first place, so to avoid that people get smoking, to avoid that people get diabetes and so on, with the final aim, of course, to avoid the appearance of CVD events. So the 2 strategies are complementary, but today I will focus on this strategy. And so once the purpose is defined, we need tools to measure to which extent this strategy is efficient. And so we developed a simple tool, like Brett was speaking. We need simple, non-invasive and cheap tool, what we call ideal cardiovascular health metrics. So it is it's a score composed of 7 metrics. We call it as well Life Simple 7. And you're all familiar with these risk factors: physical activity, diet, non-smoking, BMI. So we talk about behavioral risk factors, and also more biological risk factors: blood cholesterol, blood pressure, and blood sugar. And so for each, I won't go into the detail, but for each risk factors, there are optimal or recommended level to achieve, and the ideal world, in an ideal world, the plan would be to have optimal level for all these risk factors to achieve an ideal cardiovascular health. So you can imagine all the challenges that are behind achieving an ideal level, not only at the individual level, like people we know vulnerable population, but it also depending on contextual factors, the way you live, the where you reside, and many actors. But anyway, the plan is to make everything possible to achieve or to be closer to an ideal cardiovascular health metrics. And why? And also maybe one thing that is very important, we talk about simple tool. You can imagine, you could find that it's oversimplistic. Behind this score is the way that, the idea that maybe, because all the people know these risk factors, so by providing simple risk factors that are known by the general population, they may digest this score and this may stimulate change in their behaviors. So does it work? So there has been a lot of literature showing that indeed it works. For example, this first study coming from the US, just believe me, but showed that the higher is your the higher is your score, the lower is your risk of event. Okay. So one thing that is important in this concept is that we also use we have a positive thinking, because classically you will see in your studies as a doctor, when you see your patient, most of the time we said, okay, be careful, given your risk factors, you are at risk of suffering this kind of disease. And here it's rather in the positive way, saying that, okay, if you achieve an optimal level of risk factors, you will reduce substantially your risk of having events. So it's a more positive way of thinking, and we may believe that it's also a stimulator to adapt the behaviors. So I would like to give you some example of briefly of what we have done through collaboration with very wonderful postdoc people. That's something also very important. You will see that even in your medical practice, but in research, it's really a collective work, and you can do good things by yourself. And so the first thing we were thinking of was about the elderly population. It's a growing part of the population, and we're thinking, it's a bit provocative, but is it still worth doing health promotion in elderly people or not? Or is it too late? And so the finding of this study was that indeed, even in people who are older than 70 years of age, it's still important to stimulate them to achieve an ideal cardiovascular health for preventing the onset of CVD event. Then we moved forward, and we were thinking, okay, because most of the literature were based on the level of cardiovascular health at a single point, and we wanted to know how does it change over time? Sorry. How does it change over time? Is it declining? Is it increasing? Is it remaining stable? And is there any relationship between the change in the risk factors and the risk of CVD? And these were really interesting, because unfortunately, we see that only a few people were able to improve their cardiovascular health. And then we start thinking that maybe this tool could be also valuable beyond CVD, because as you may know, there are common risk factors between many chronic diseases. And we start thinking about the impact of type 2 diabetes, and also the impact on mental health, and so or brain health. So we work on cognitive decline and dementia, and more recently on the risk of depression. And you start seeing that with a tool that was initially developed for preventing CVD disease, step by step, you see that it can have an impact on very important chronic disease, like I just mentioned. And even maybe more unexpected, we did find some clear risk reduction for the risk of cancer. So taken together with this approach, we believe that it might be viewed as a unified approach to prevent potentially a lot of chronic disease with a huge impact on public health. The problem is that when you look at this table, it's a worldwide analysis showing that in fact, at best, only 15% of the population achieve an ideal cardiovascular health. So the second important message is that we need to intervene to increase the number of people being close to this ideal CVH, and you can imagine all the challenge that we were able to face. I already talked about this. It's about the way you reside, it's about the way you behave, it's about mental health, it's about political decision, it's about, we're talking about public health environment and so on. So it's beyond medicine itself, it's much more than that. It's public health, in fact. And so I will end with this slide showing that, in fact, at the European level, they are highly aware of this problem, and in the Horizon grant, it's funding opportunities. There's a call named Staying Healthy in a Rapidly Changing Society, and in my team and with European colleagues, we are applying to this call. And when you look at the call in details, you have keywords that echo with what I've just mentioned. It's about prevention, empowerment, health literacy, digital tool, because the plan is in these modern societies to use digital tools as a driver to promote intervention, and it's about also prevention of digital addiction. So just to say that it's a real, so we have opportunity, but it's really time for intervention, and we are facing a lot of challenges for this. Thank you for your attention.
Thank you, Jean-Philippe. That was very instructive. So, speaking about the burden of cardiovascular diseases and those many years living with disability and also many events of premature mortality, we cannot avoid to target the most important population speaking about this burden, and those are older people, those who are older than 65. And now we will listen what are the typical health problems and how they can maybe be deprived when we are speaking about older people. Our professor from our faculty, Bojana Matejic, who is head of our program in English, will open to you this topic, and you will see why many of your patients, when tomorrow you become doctor, actually will belong to this population group. So listen why that is global health problem.
Thank you, Vesna. Hello, dear students, distinguished guests, friends, public. I'm very happy to be here today and to be the part of Circle U academic environment. And today we are gathered together to speak about some interesting and important public health and global health challenges. And among them is, of course, the pandemic of COVID-19. And I have chosen one topic that's interesting, and my short presentation is dedicated to the older people during the COVID-19 pandemic and the risk of social isolation. So that's the topic. Social isolation and loneliness are very prominent public health problems all around the world, but still we can say that there are neglected problems. We just heard from our dear Professor Empana about the cardiovascular risk and 7 important factors, but the social factors are very important as well. So let's define just a little bit what is social isolation, what is loneliness. These two terms are very interconnected, but they're not the same. When we say social isolation, it is objective state of having a small network of kin or non-kin relationship, and these relationships are inadequate. But when we say loneliness, it is a very subjective feeling. It's emotional isolation, or sometimes in the papers is called social pain. What does it mean? It's the way an older person or any person perceives social isolation and feel disconnected from each other. So you can see that these terms are related, but when we start to analyze the connection, it is not so statistically well sound, the connection. Sometimes you can be social isolated as a person, but not necessarily lonely, and vice versa. So why are we talking about the social isolation in the population of older people? Because they are usually more social isolated than the others. And the times of public health crisis like pandemia is the time when that fact is even more present. So we know also from the studies, there are a lot of empirical data that social isolation is bad for health, and for the older people especially. It is related with multiple negative effects on the health and quality of life of older persons. It is connected with also cardiovascular risk of cardiovascular diseases, even malignant diseases, then major problems from mental health domain like depression, anxiety, problems with sleeping, but also social isolation is associated with a level of physical activity, and this is an additional risk. The social isolated people are less physically active, and so it is associated with their quality of life and, of course, physical abilities. So more than 10 years ago, this was an interesting findings from Holt, Lundstedt and the authors when they stated clearly that the health risk associated with long-term social isolation are equivalent to the harmful effects of smoking and obesity. And these are the risk factors which are more often assessed through the surveys and all sorts of investigations in the science. So we must focus on the social factors as well. During the time of COVID-19, from the beginning, it was well known that the older people were at the highest risk for COVID-19. We are not going to talk today about their mortality, about the incidence rates. You already know that they were in a higher risk. But today, I want to emphasize that the older persons all around the world were in the higher risk of social isolation as well. So we expected that the lockdown would affect many dimensions of life as well as the health, as I mentioned in the previous slide, and that some of the surveys will demonstrate that. So we have one very good and the results of a very good review paper. It's a scoping review regarding the social isolation of older people during the COVID-19. And the results were very clear that the social isolation among the people more than 65 years is mainly connected to the mental health status. You see the prevalence of major concerns, anxiety, depression, sleep disorder, and physical inactivity as well. So we are not so I just want to emphasize that at the very beginning of the pandemic, one research from USA clearly stated that lack of social contact is the biggest challenge in the lives of older people during the pandemics. And it is interesting because it was not the fear of the COVID-19, of the complications of the death. It was the lack of social contact in the population of older people. So even more, some of the subpopulations of older people were at the highest risk. So I named only, this is not the whole list. These are from the very huge researchers. So older women, people living alone or homeless with a negative perception of aging, then people who were frequently exposed to the news about the COVID-19, then older people with chronic health conditions, victims of violence, and persons depending on caregivers. That leads us to the biggest issue here, because many of the surveys demonstrated very clearly that the pandemic has a much huger effect on older persons who live in long-term care facilities than who live at home. So here are some of the reasons why the long-term care, you know, the institutions of long-term care are different in different countries. They can be nursing homes or institutions of social care, but they're somewhere between the social and health care. And usually they're connected with these shortcomings all around the world. So we saw the risk, we saw, I talked about some issues connected to the social isolation, but let's see some of the recommendations based on the data I presented. So, interesting, Brown and Reid said that locking up our older people, different measures were around the world, but that was it, locking up, unlocked the social capital of entire community. That means the social capital, all resources around the old people. So we have to support not only the health services, social services, but also the intergenerational solidarity in the society, and to support informal caregivers, because 80% of older people are not in the institutions of care, but they are at homes depending on informal caregivers, and to support the NGO sector who is dealing with the aging population, and volunteering in the community is very important to combat or to address social isolation. There are huge data about individual relationship, community, and societal level of strategy. Societal means policies and programs. I'm not going to talk about this. But during the times of crisis, like pandemic is, the most important was instrumental health. What does it mean? To support older people with all necessities for everyday life, with food, with medicine, with hygiene supplies, everything. But also, don't forget that we had to provide tailored and accurate information for older people. That was the problem. And one survey stated, it is a qualitative research, that society could have done more for us, for older people, during the pandemic to protect us from too much information. That this is infodemia, and we have our infodemic managers here. They can participate in discussion later on. So the informations were also very important. And also, the times of pandemic highlighted the problem of digital literacy among the older people. In our country, we have some data about only 40% of our people older than 65 knows how to use the internet, and less than 10% use social media. And that was very important during the pandemic. So all kinds of digital interventions are very important to combat social isolation. And of course, the question of evidence, because if we want to improve something, we must measure it. So that is a huge methodological question and issue about how to measure social isolation. And to finish with this presentation, I want to say that all public health crises, pandemics, and some other crises are somehow here to learn, to teach us how to act, how to plan better. And one of the important issues for our planning should be the preventing of social isolation among the older people. So thank you.
You heard about older people. Now I would encourage us to return back to opposite end and speak again about the beginning of life, which is actually light of the global health. And for that end, I invite our guest, Dr. Josephine Aikpitanyi from Catholic University of Louvain. She just 2 days ago became Doctor of Science. So, Josephine, will you tell us about maternal and child health to see what is for us as global health activists?
Thank you very much.
Thank you.
Thank you, Professor Bojana, for inviting me to Belgrade. It's my first time in this part of the world. I'm happy to be here. Thank you for coming today, everyone. My name is Josephine, and as you just heard, I just became Dr. Josephine. So thank you. So this morning, I'm going to be speaking on the challenges of maternal and child health in a low-resource setting. And that means I'm speaking on the challenges from the point of view of someone coming from a low-resource setting. Pregnancy, that's the maternal health period, is a period of pregnancy. That period is supposed to be one of the most important periods in the life of a woman and her family, because it's supposed to be the time of life, but sadly, for so many women, that period becomes a period of pain, a period of suffering, because a lot of women are dying when they should not. One pregnant woman dies every 2 minutes. That's less than the time it takes for you to brush your teeth. A woman is dying. And that leads to 295,000 global deaths. pregnant women in the period of birthing and bringing forth life. 90% of those deaths occur in low and middle income countries. 2/3 of these occur in sub-Saharan Africa, where I am from. The ironical thing here is that most of these deaths are preventable. So we have the global maternal mortality rate at 211 per 100,000 live births, but in least developed countries, it is 415, and that means it is 40 times more than what occurs in Europe. So maternal death, what is it? It is the death of a woman during pregnancy, while pregnant, or within 42 days after the termination of a pregnancy, irrespective of the duration of the site of the pregnancy, from any cause related to or aggravated by that pregnancy, and not from accidental or incidental causes. That means if a pregnant woman is involved in a motor accident, it is not counted as a maternal death. So maternal death must be a death that is related or caused by the pregnancy and its management. Then the maternal mortality ratio, as I have just said here, is defined as the number of maternal deaths in a given time period per 100,000 live births in the same period. So this map that is adapted from the World Health Organization shows the parts of the world where you have high rates of maternal mortality. You see the darker colored parts shows that, the darker colored part shows high levels of maternal deaths, up to 500 per 100,000 live births, 1,000 per 100,000 live births. I am a Nigerian. I am from Nigeria. So it is one of the countries in the world with the highest number of women dying daily from maternal-related causes, followed by India, and then you have the Democratic Republic of Congo, Ethiopia, and all. These are because of inequalities. A lot of women are poor, they have low education, live in the rural area, and other causes. And then we speak about mortality. Know that it is not just mortality, because for every woman, for every one woman that died, 20 to 30 others suffer from complications, other forms of complications. There are 2 million near misses annually. A near miss is a woman that would have died, but maybe an intervention was put in place at that moment that helped her to survive. But she lives with debilitating diseases or issues. There are 27 million more episodes of other serious morbidities leading to depression, diabetes, and other minor illnesses. These complications lead to long-term effects in the woman. Examples of such could be the obstetric fistula. You are medical doctors and you know what that could be. And also, one of the parts of the babies, there are 2.6 million stillbirths annually. Over half of these occur during the period of labor, during that time of labor. And 1 other million infants will die shortly after birth, and another 2.9 million will die within the first 28 days of life. What are women dying from? Like Professor just said from Harvard, most of the maternal deaths is caused by postpartum hemorrhage. Postpartum hemorrhage refers to bleeding, excessive bleeding during the time of childbirth. This excessive bleeding will lead to hemorrhagic shock that will lead to the death of the woman. But I am happy that there is a cost-effective solution, and that is something that I think that Professor will have to take. I just told him he has to take that kind of information to Nigeria, where we can start seeing that less women are dying from postpartum hemorrhage. And then you have other causes like pregnancy-induced hypertension that could lead to eclampsia, preeclampsia, and you know that severe eclampsia will lead to coma, and sometimes the women don't come out from the coma. The coma leads to death. There is unsafe abortion, sepsis, embolism, and other indirect causes that are aggravated by the pregnancy, such as malaria. When a woman has untreated malaria during pregnancy, it is very difficult because that untreated malaria may lead to complications in the pregnancy. Also, HIV could lead to more complications during the pregnancy. The timing of maternal death becomes also very important, especially for doctors, because a case like postpartum hemorrhage, if it is occurring, a woman dies within 3 hours. She loses all the blood and is gone. Most women die on the first day during pregnancy, and that the first day within delivery. So as time, the first 3 days are the most critical periods in the life of a woman that is just given birth. These maternal deaths are like the causes. How does it come about in the life of the woman? What leads to it actually? So I present the 3 delay models that was formulated by Tadas and Main in the late 90s. The first delay of accessing healthcare, if like what we have said, like knowing the causes, the medical causes of maternal mortality, is sure that when a woman gets to the hospital on time, something can be done. But then the 3 delays of maternal mortality becomes very important, because if there is the first delay, which is the delay that it takes for a woman to make the decision to seek health care, then there is a problem. Statistics have shown that the first delay leads to 40%, contributes 40% to maternal deaths. The second delay is in the delay to reach care. That is the delay of transportation, getting to the healthcare facility, bad roads, time. It leads to 20%, contributes 20% to maternal death. And then the third delay happens when she is eventually in the healthcare facility. One of the global challenges of maternal health, the global challenges of health, maternal, as the professor said, is that in low-income settings, there is the inefficient healthcare system. So the third delay in maternal health-related causes contributes another 40% to maternal death. When the woman gets to care and she is bleeding, and there is nothing, or there is no blood in the blood bank, like a study that I did before, there is no blood in the blood bank, you know that she's going to die. Nothing is going to save her. So this contributes 40% to maternal mortality. To improve maternal health, the World Health Organization has said that a woman should have antenatal care, which is the care that she gets during the course of pregnancy. Also, a skilled birth attendant should be present during childbirth in case there are complications. And to have postnatal care, like you saw in the graph, the first 3 days are very important. So if a woman has postnatal care for the first 48 hours during childbirth, then a lot of things could be put right. These 3 components of maternal health care maternal health service utilization can be delivered by the skilled birth attendant. So most of you here are going to be, you're already in the medical sciences, so maybe you're going to get training as gynecologists or obstetricians, and so you qualify as a skilled birth attendant. That is an accredited healthcare professional that is trained and educated to proficiency in the management, in the skills needed to manage pregnancies, childbirth, and the postnatal period, and can help in the identification, management, and referral of complications in women and newborns. So how do we bridge the gap a little between the high-income countries and the low-income countries? A lot still needs to be done. But with adequate funding, there's no way we cannot talk about funding because it's one of the challenges of global health. So in low resource setting, for example, the health system, the Ministry of Health, there is no much financing. Like Prof said, you have governments budgeting $20 per year for someone, and so it's already very low. Most of the funding comes from donor agencies, from AIDS, and international bodies. So if we get more adequate funding, and the funding is managed right, then it could be good. Also, we promote the education of girls. Girls, I say it when I make presentations at home, girls. Women should be educated. If a lot of women are educated, the problem of the first delay will be, I think, avoided, because the low levels of education makes it impossible for some women to go to the healthcare center on their own without the approval of their husbands. So we should also ensure the presence of strong political will. That is something that is lacking in low resource setting. Gender equality, which is linked to education. A woman's voice should be amplified. That's the focus of my PhD thesis, and I know that I'll come again to Serbia to give another lecture on my PhD thesis. So there should be the effective data management systems. Things should be put in place to strengthen the healthcare system, and above all, in Africa and other low resource settings, we need good governance. Because with good governance and good funding, I think good governance is more important than the funding. Because if you have bad governance, the funding will be misappropriated. And so that is it. Thank you.
Thank you, Josephine.
Thank you,
This
Mom.
was very helpful
Thank
to
you.
learn about right? But now let us go a little far away from health problems, but still close to them. And let us see and highlight what is going with the global citizens' behavior. Sometimes they avoid to use preventive practices, for which practices we know that they are not only cost-effective, but the most efficient in prevention of diseases. And a lot of examples during COVID-19 pointed to that. Now I will invite our colleague, Dr. Vesna Bjegovic-Mikanovic from University of Pisa. She is medical doctor, but she is on specialization in public health. Very promising specialization of medicine. And please, Virginia, tell us what you learned about vaccine hesitancy as behavior which we must avoid.
Of course. Good morning, everyone, and thank you for the introduction and for inviting me in this event. It's a pleasure for me to be here. So we are going to talk about vaccine hesitancy, and probably most of you have already heard many times, a lot of time about vaccine hesitancy, I guess, and also about the definition of vaccine hesitancy. Okay. So, okay, I missed a slide. Okay, I'm here. Okay, so but however, you know the definition of vaccine hesitancy, and it is well known. But however, there is a lack of conceptual clarity in literature on vaccine hesitancy, because many times we use terms like low uptake or low intention to vaccinate often are equal of vaccine hesitancy, and there are also many shades of meaning for this. So we need a renewed definition, and we can say that vaccine hesitancy is a psychological state of indecisiveness that people may experience when making a decision regarding vaccination. This is a recent systematic review on the topic. And we know also that vaccine hesitancy is a global threat, and not only we know that WHO named vaccine hesitancy as one of the top 10 threats to global health, but also we need to assess and to monitor how the pandemic may have affected the vaccine confidence. And in a recent study in a cohort on UK, it seems that probably vaccine confidence declined after the pandemic, and it can be maybe also counterintuitive, no? Because the vaccination campaign for COVID-19 was a success and was in many countries now, not? And now in this figure, we can say that in this image, the vaccine hesitancy is continuum, and the vaccine hesitant moment, as defined by Heidi Larsson, that is, I think, one of the most important researchers in this field, it is a time of vulnerability, of course, but it is also an opportunity for us to intervene. So to do an intervention on vaccine hesitancy. We know that there are a lot of factors that may affect the decision of a person to vaccinate and to get vaccinated. We know that vaccine hesitancy also is vaccine dependent, vary across time and space. But the real question is, how do people decide? So to answer to this question, we need to go also in other fields. So in psychology, maybe there are some students of psychology, I don't know, and especially in behavioral science and economics, because we are used to seeing that the human being decide completely rationally, but evidence says that it's not like this, it's not in this way. And when we face especially complex decision on we have to decide fast, we can resort to some mental shortcuts that are called heuristics. But these mental shortcuts can induce us in errors, and we call these errors cognitive biases, and they may influence our judgment. And here is an example. Confirmation bias is one of the most studied, especially because on social media we know now the echo chambers and how people search on internet and on social media to confirm their beliefs and their opinions. So the confirmation bias is really relevant, especially about vaccination. And here I present in this figure also the enhancing vaccination model that is created by the WHO. And we see that it's a long path, no? From the intention and to get vaccinated, and then at the end, the decision and the action. So it is important to distinguish between vaccine hesitancy and then the action. And also behavioral science and economics, and especially heuristics and cognitive bias can act in different parts of this path. Okay, so now I'm going to present some results of a study we conducted at University of Pisa with the group I have the pleasure to work with, and also with the IMT, that is a school of advanced studies in Lucca, that is a city close to Pisa. And we did an online survey. We recruited more than 900 parents, mostly women, with a median age of 41 years, and the education level was generally high. And we investigated these for domains, so demographic information and vaccine hesitancy that we measured through a vaccine confidence index. Then we measure riding risk aversion and free riding effect. And we administer this conspiracy mentality questionnaire. And of course, at the end, we try to understand the association between cognitive biases and vaccine hesitancy. We used a 5-point Likert scale for each of the biases that I listed here. And what we find out. So we found out that in our sample, vaccine hesitancy was quite low, so we had a good vaccine acceptance. And we found that vaccine hesitancy was correlated with each of biases I showed before. And so higher score in the bias corresponding to higher score in vaccine hesitancy. Then we perform an exploratory factor analysis. So basically, then 4 latent factors emerged from the items we use to investigate the cognitive biases. So we saw how the items we use in the Likert scale then can be combined to obtain some profiles. So these 4 latent factors depicting 4 different individual profiles. We have the skeptic one, so a skeptic person, then the denialist, we can say, the optimist, and also the optimism bias is one of the mass study, also in COVID-19 pandemic, because it's something like other people are more likely to get COVID-19 than me. That is basically the optimistic bias. And then people usually prefer for natural products. And then we saw how vaccine hesitancy was associated with these factors, and we see that it was positively associated with all these 4 latent factors, but also with risk propensity and conspiracy mentality. However, for the free riding effect, we did not found a significant association, so we need also to explore more the role of social norms and all social norms and collective responsibility on vaccine hesitancy. So to conclude, cognitive biases influence our decision making and also our judgment. And so for this reason, we need to take into account this factor and should include evaluation of cognitive biases and heuristics on the model to analyze vaccine hesitancy. And this is really important because the knowledge of these elements can help healthcare providers, so can help us basically, in orienting and supporting the parents' decision. And I would like to remark this point because probably, despite what we are thinking, the healthcare providers are still the most trusted person when it comes to healthcare advice. So our role in communication with patients is really important. Thank you.
That was really for us interesting, particularly because at our Faculty of Medicine we have dedicated colleagues, Dr. Stefan Mandić-Rajčević, Dr. Aleksandar Stefanović, who are certified in pandemic managers and also investigate and prevent vaccine hesitancy, so you can discuss with them. But now, speaking about only few global health challenges today, the most important is how to secure global health, and do we have any platform which will help us on that way? Many people say, okay, we can see what is for us in international health regulation, and now I have pleasure to present to you our very truly dedicated professional working in the World Health Organization, country office of Serbia, Miljan Rancic, who actually invests a lot of efforts and activities to prevent and early respond to health emergencies and any global health issue and threat. Please, Miljan, highlight what you suggest to us from international health regulation.
Thank you very much, Professor Bjegovic. Hello, everyone. I want to say at the beginning that apparently I'm the only one not coming from the academic environment at the moment or among these lecturers today, presenters. But I'm really honored that I had have the opportunity actually to bring closer to you what is the WHO role in the world in one specific part, and what are the WHO policies when it comes to all kinds of emergencies. So the COVID-19 actually is considered one of the biggest health emergencies that world ever faced, actually. And now you will see what is important to mention, what is WHO doing to prevent this kind of health emergencies and to mitigate the possible negative effects. So what is the role and what are the regulations that we rely on? So in the title of my presentation, you have international health regulations. We'll see later on what it is actually. So before that, I would like just to emphasize that WHO, as a UN agency specialized for health, has actually directing and coordinating authority and plays the main role in so-called health cluster among all health organizations in the world. And it is actually in charge, coordinating and directing authority on international health within the UN system. And how WHO operates. Actually, the whole work of WHO is based on 5-year general programs of work. Since it was established back in 1948, currently we have in place 13th global program of work. WHO is member state-driven organization, meaning that these programs, general programs of work, are always brought up by the member states. So usually among many theories, or conspiracy theories, of course, usually there is a picture that WHO is kind of separate organization, totally autonomous, that imposes some policies to the world and things like that, which is actually not truth. All the policies, tasks, and functions that WHO has are actually always brought up jointly by all member states. So they all actively participate in it. So current general program of work that is ongoing now has 3 main pillars. Of course, the most important, they are interconnected and overlapping, as you can see in this figure. Let's say the most important one, they are equally important, but let's say the most important one is to provide within the period of 5 years, 1 billion people more that benefit from universal health coverage, or actually achieving the universal health coverage. And of course, 1 billion people more enjoying better health and lifestyle, quality of life, actually promoting the health and well-being. And I put it at the third place, 1 billion people more better protected from health emergencies. So that one was set actually back in 2019. It kind of anticipated COVID, emphasizing the importance of prevention of health emergencies at global level. We're dealing today, the main subject actually of today's presentations is global health. And I'm mentioning here international health. So these 2 concepts are very similar, but actually not exactly the same. The meaning is slightly different. So meaning that international health is kind of broader concept than the global health is. Meaning that international health covers all aspects of international health for each and every groups, including those in high-income countries. On the other side, the global health is more likely to be dealing with vulnerable groups and less developed countries, low-income countries, to support where the need is bigger. Also, you are all aware that there is a Sustainable Development Agenda 2030. It was brought up with the UN, and there are Sustainable Development Goals. I'm quite sure that you're familiar with the concept of SDGs, actually. So in a target 3D, it is envisaged that the countries are committed to permanently strengthen the capacity of, in particular, developing countries, capacities for early warning, early detection, risk reduction, and management of national and global health risks. And there is an indicator 3D1 that mentions actually the international health regulations by its name, saying that it is important capacity and health emergency preparedness. So it is a kind of obligation of all countries to work with international health regulation. So what it actually is. International health regulations, the current version edition that is currently in force, has been developed actually back in 2005 and came into force in 2007. So until recently, it was actually the only legally bounding actually document at global level dealing with health. So once the country ratifies the international health regulation, there are obligations for a country, what they need to do. And what is it all about, actually? So it is a document that has actually a goal or aiming to strengthen capacities of all countries at global level to be prepared to prevent, to mitigate, to be able to early detect, to prepare properly, to be able to rapidly and properly respond, and to ensure the good recovery from any kind of health emergencies. So how to contextualize this, how to put it into reality? It is always a challenge when you brought up that kind of big strategies or even legally binding documents. It is always a challenge how to ensure its implementation in reality, in life. What can we do to make it real, actually, not to stay just as a proclamation of goals? So what it means, countries, I underlined countries because I emphasize member states. WHO is not a separate autonomous organization, it is member state-driven organization, are obliged to develop, maintain, and permanently strengthen, upgrade, multi-sectoral. Each and every word is actually important. Capacities to prevent, as I said earlier, early detect, properly prepare for, rapidly respond to all kinds of health threats. So the earlier versions of international health regulations were dealing only with so-called 6 quarantine disease, meaning plague, cholera, yellow fever, smallpox, and 2 versions of typhus, lice-borne typhus and lice-borne recurrent fever. And that one was actually in force since 1969. But meantime, during to the big technological development all over the world and increased trade and travel of people and everything, so-called globalization. So it became pretty clear that there are also other health threats, meaning threats from chemical accidents, possible nuclear or atomic accidents and things like that. Back in 1986, there was a Chernobyl accident, one of the biggest ones in history. Then in 2011, Fukushima, Japan, and everything. So the latest edition of IHR that is currently in place and in force from 2005 actually promotes and implements 2 kinds of approaches, very important principles. One is all hazard approach, the one that I just explained. So not only the infectious disease, of course they have a biggest potential to affect the biggest number of people like COVID did recently, but still we cannot neglect other threats, as I said, so all hazard approach. Again, there is a pretty new concept now, one health approach. I don't know if you are aware as students of medical faculty, when we speak about infectious diseases, 70% of them that affect people are actually of zoonotic origin. So that's why it is important, if you would like to really provide early prevention, to think early, meaning to do something before the agents come to a human population. So it means actually to establish a very functional relationship with people who are dealing with animal health, but also with so-called environmental health. There are many new concepts, new terms, new syntax, but it makes sense. When it comes to environmental health, we all speak in Belgrade, it's familiar, that air pollution. Of course, it is connected and it affects health. And it doesn't know boundaries and international borders. Air pollution can affect neighboring countries as well. So that's why one health approach is very, very important one. Also to make an interconnection, interoperability between different disciplines. What is also important to say among the major things that are important to be mentioned regarding the IHR. WHO is, as I already mentioned, a kind of custodian of the IHR, International Health Regulations, IHR, having a leading and coordinating role on its implementation. And there is a full set of activities defined that go under the monitoring and evaluation framework. There are many tools. I cannot now spend time on that. What are the mechanisms? How from global level it's been checked every year, evaluated and assessed the progress of countries in strengthening their capacities to, as we said, to prevent, to early detect and be prepared for and rapidly and efficiently respond to emergencies. And Serbia is part of it. There is a mandatory annual reporting on IHR capacities, and then there are some voluntary tools that are being implemented. And fake. Of course, WHO, as all UN agency, we like very much acronyms. So usually that was the funny one during the COVID, which stands actually for Public Health Emergency of International Concern. It is official thing that has been declared back on 30th of January 2020. There is a full mechanism how you declare. You cannot declare whatever you want. So far, it was only 6 times that the fake Public Health Emergency of International Concern was declared. It was with Ebola twice in Central Africa, West Africa and Central Africa. It was with Zika virus. It happens with COVID-19. But I just told it is funny because when you pronounce that fake, there were kind of funny interpretations back in 2020 when WHO declared it fake. People said, "Oh, come on, then COVID is fake." But it's not fake. It is Public Health Emergency of International Concern. And the final one, usually all of my colleagues ended up with their presentations putting this kind of positive things at the last slide, affirmative, saying what are the recommendations, what is the future. But I put weaknesses, which in sort of a way actually indicate what are the positive aspects and what should be done in the future. So what are the restraints, what are the weaknesses or weak sides of implementing international health regulations as a mechanism to ensure as much as possible that countries are ready to prevent health emergencies? And just to make a quick link with the global health. When I speak about the health emergencies, at the first glance, it might not look that it is very much connected with what global health is, but actually it is, because we know that the natural disasters, they usually hit, not necessarily, but equatorial geographic area where many countries, low-income countries are. So big floods, droughts, and things like that. So the health emergency actually affects. Also, it is kind of logical thing that if you have a weak or undeveloped health system in place, there is a big. It is really likely that any health emergency will strike harder that kind of system than the one which is high developed and things like that. That is where this concept of international health regulations is actually really connected to global health, and there are many efforts not only by WHO but the whole international community to strengthen health systems in low-income countries, also to lessen and to mitigate possible effects of any kind of emergencies, of health emergencies. So what are the weaknesses now? This one, I said, until recently, it was the only one globally legally binding document in the area of health. But unfortunately, me personally, I'm not very much satisfied with the certain provisions, because when it comes to the international trade, when it comes to the international economy, those pieces of legislation have penal provisions, meaning that if you do not obey it in international trade, the country can be sued and prosecuted actually on international courts and pay some I don't know, certain amount of money or whatever. But when it comes to international health regulations, despite the fact that we all agree that the health is the most important value that we are dealing with, still there are no penal provisions. And it makes the international health regulation implementation weaker. And we saw some, I won't give you an idea for questions, so some effects recently. And it is hard to find also a good balance between state parties' sovereignty, because each and every country, internationally recognized country, is sovereign to make its own decisions concerning the health of its population, and nobody can challenge that one. But at the same time, there is a global interest. We always say, as WHO, we always say, no one now in COVID, no one is safe until everyone is safe. So that's why it is important for each and every country to implement the same measures if you would like to prevent spreading the COVID or whatever the health threat is. So it is, as I mentioned here, it is really challenging to find a good balance between the sovereignty, and it is very much connected with the third bullet point, saying that political aspect of health-related decision-making is important. What it means we all saw that. For me, we saw that in our country, that many decisions were made from a political level rather than maybe from expert level. But we also, it is not exclusively linked to Serbia. Even in the most developed countries, here we have Professor Brett Nelson, even in the United States at some point under the ex-president Trump, there were really controversial approaches to dealing with COVID and everything. So political aspect, and we also as WHO and UN, we introduced the concept of decision makers and put them, of course, it's logical, at the highest top. So even above the experts in the field, but that's how it is at global level. But it is a challenge for the implementation of IHR. Reporting, why I put that mark in the end of reporting, because reporting sounds like a very much bureaucratic thing. So why it is important to make a reporting? Because reporting, someone said, of my colleagues today, that the generation of evidence is very much important. I think Bojana said that, Professor Matejic said that, because you cannot make a good decision and improve situation if you don't deal with the reliable evidence. To produce evidence, you need to report, and in a uniform way, and to gather data from all over the world. So also during the COVID, it was challenging to get some needed data to make a global conclusions about transmissivity of COVID-19 and many other things, because some countries were not very much willing to share real data or affected cases, confirmed cases, or deaths, or this and that. So there are many challenges, but of course it doesn't mean that we need to give up on implementing the international health regulation. And instead of usual slide over the end, allegedly we're kind of making a difference between equality and equity, meaning, so the first part of a photo shows that you can allocate the available resources equally to everyone. But it's actually not fair, because not everyone has the same need. So it seems like this man, he even didn't need that kind of chair or improvised chair to see the game over there. But he got the same amount of resources. And that one is, unfortunately, by nature, short guy, and he cannot use, even in the most useful way, his resources that were allocated to him. Here is the equity, actually the most important one. So those who are strong enough and not need resources, they need to share it with those who are in need. And unfortunately, frequently, oftenly, this is reality, actually, that those who have, they have more. But okay, it doesn't have to be that pessimistic. So international health regulation is important. Tomorrow, when you become a medical doctor, have that in mind. Maybe not many of you will be dealing with preventive branches. Many of you will be most likely oriented toward clinical disciplines, but still have in mind the prevention of health emergencies. Sorry if I exceeded the allocated time. Thank you very much. Thank you very much.
Thank you, it was very useful. Now is the time for sharing questions, answers, and eventually proposals for improvements. Do you have any burning question to our lecturers? Okay. I have one, because I was always curious how to involve more myself in the global health activities, and I managed to actually, coming from Belgrade University, it's a very good place to start your global health career. But I will use the opportunity to ask Brett. Brett, How can we boost up our international cooperation and improve global health? Are there any prescriptions by you which you can share with us?
Prescriptions for improving participation in global health?
Yes, cooperation and participation. What would be
Brett, I will
our
give you a microphone.
options?
Again.
Thank you for the question. So I believe the question is, how can we improve collaboration and cooperation within global health? I loved your discussion and the role that WHO plays in being a central collaborator and facilitator. You also alluded to the cluster system, which is really helpful. So oftentimes our interventions are organized by clusters. For example, we might have a medical cluster, or we might have a nutrition cluster, a women's health cluster. So if you're ever responding to a disaster or working in a low resource setting, be aware of the cluster system, because this is an opportunity where non-governmental organizations and international organizations come together with shared interests. For example, malnutrition, and all those that are working on malnutrition come together and collaborate. So I think this type of networking has been really helpful. And then another important player and stakeholder are the ministries of health. They certainly know their country best, and they should guide us in how to effectively, what is needed and how to implement that. So I think those are some of the things that come to mind. As a WHO expert, is there anything that you would add to that? No. Oh, okay. Okay, great.
Thank you, Brett. Speaking about cardiovascular health, I would like that we all know where to start. What is our first target? And Jean-Philippe, can you tell us what are these main barriers to achieve an ideal cardiovascular health? Do we have something to address more?
Yes, so that's a very important question, because we and other, I mean, as I mentioned, the goal is to achieve or to be close to this ideal cardiovascular health, but there are many barriers in low and high income country, and it's related to the question I had for you, but maybe you will answer after that. It's we put a lot of we talk a lot about health literacy education, so we put a lot of emphasis or responsibility on the shoulders of the population, of the individual population. And I'm saying that because we had a discussion with some of our chairs from Circle U, who were saying that, okay, maybe we put too much responsibility on the shoulders of the population. And so how could we overcome of this? But so there are the individual in terms of education, health literacy, meaning the capacity to get access to the information and to digest the information and to then go to the change. But we have seen with our colleague from Italy that there were several steps from having information to behave accordingly. Like when you want to stop smoking, it takes a long time. So we have barriers at the individual level. So and in my team, we investigated mental health problem. Well, we investigate in vulnerable population mental health problem. We compare men and women, and there are strong disparities according to sex. We, of course, look for socioeconomic factors. And you were talking, Bojana, in terms of social determinants, it's a huge impact. And also one important factor is about where you live. So, of course, when you say to people, you should eat like this, or you should do physical exercise, when you have no facilities to do that, it's very complicated to so it's a very complex issue that include both individual but also the what we call contextual factors.
Okay, thank you, Jean. Still, you can write your question through slide. Don't forget. But yes, in relation to all these barriers. Bojana mentioned neglected social determinant of health, which is relating to social inclusion. Do we know, Bojana, any efficient strategies to deal with the social exclusion in general?
Okay. see this. Thank you for the question. Yes, COVID-19 pandemic just make these social determinants of health more visible, but they were existing. And thank you, Professor Empana. That's right, we need to focus more on these factors. And interestingly, in some countries, they're starting to prepare different policies and programs to address the social isolation and loneliness among the population, because you all know we are living in the aging world. So in Europe and North America especially. So in UK, for example, in 2018, their government appointed a Ministry for Loneliness. They prepared the strategies to battle the loneliness. Of course, partly due to pandemic, in Japan in 2021, I think they also appointed a task force for loneliness and Ministry for Loneliness. Then in US, I think that you have a very good strategy prepared to address these issues, and WHO also prepared a very good, it is a policy brief. They name it advocacy brief. And this is actually a framework for other countries to prepare the similar documents. So these are the documents that could be implemented any time, but during the time of a public health crisis, it is even more important to address these issues.
Thank you, Bob. So we have now here a question from the audience. How can we, as students at our level, help you deal with all these issues? Thank you so much. So brilliant question. Who has from our panelists answer? Or Stefan? Stefan, our colleague.
Our students, they're probably sick of looking at us. But just to give you, we come, Alexander and I come from the field of behavior change. So I want to give you a small actionable step that you can take if you're not sick of us. You can come approach us at any time or send us an email saying, we are interested in this issue, we would like to participate. And we will, if it's not something that we do, we will direct you to the person who is the right person to put you in touch with these topics and maybe help you learn more, and then you can also, help and make a change. But maybe also some of the panelists can answer.
Jean.
No, I think it's an question and challenging question, but so I will talk on behalf of my field, which is again cardiovascular health. But to me, the first important thing is that you get aware about all these problems in terms of related to prevention, but also to maternal health, or to have a global vision of health in general, not only focused on your own country or your own region. So first of all, having a awareness about the problems. And regarding my field in cardiovascular health, as I mentioned, it's really time. We have the evidence that this strategy might be useful, but now it's time for intervention. There are a few interventions in children early on life, and now what you could do, for example, I briefly mentioned a European grant I'm applying to, and the plan is to launch a European intervention trial at different age in different European country. And one very important keyword is about co-designing this intervention, meaning that we will organize session with children, their family, their teachers, to see what are their expectations. And I really believe that as a student, earlier on your career, this kind of approach might be very useful for you, not only for the field of CVD, but also for other fields. And I also would say, it's a joke, but that our politicians should be invited to this co-design session, because usually in the political way of life, it's most often vertical decision, and here we try to have a co-design, collective decision around this. So I really believe that in the field of intervention, you have your role to play to contribute to the discussion with the target population.
Thank you. Me? Yeah, of course, sure.
What just came to my mind also, thank you, Jean-Philippe. So WHO is also, over the last several years, largely promoting collaboration with non-governmental organizations within the concept of community engagement. It is known as such, community engagement. Meaning for you in particular, to answer your questions, though you are still undergraduates, you can try to find your area or a field where you can support, for instance, Red Cross or some other organization, and with your knowledge that you already have, you're still not graduated students, but you have knowledge, you can contribute in all these areas actually that we mentioned, and preventing cardiovascular disease, maternity and child health care, also supporting those who are in long-term care facilities, not only the older people, but other people as well. Those kind of organizations at community level are always very much, they are welcoming actually medical students. So that can be the field. We mentioned yesterday or day before yesterday, I'm not quite sure, we had some internal within the master course on public health mentioning the concept of altruism. That is important, that you have a good will actually to support. And taking into account that you already have medical knowledge, it will be really, your support will be really welcomed by many organizations.
Thank you. Any other question? Oh, yeah. Having in mind the budget for health, is there any action that we could take in order to make Serbia a better place to live? Me? Yes, I would say today this event was a widely open door for you to enter the world of global health. And yes, we have to learn from other countries and good experience. If we do not improve here our Serbia, we will not make any step further in the global health. Be aware. And please, when you graduate medical study, stay in Serbia. Don't make Serbia suffering from brain drain. Don't go to other fancy places. Stay in Serbia and help from the Serbia to the people of the world. Help to people in Africa, in Central Asia. Help people in Ukraine. And yes, please be involved in the global health, coming through the door of Serbia and returning back always to Serbia. That's my message. And we do not need for preventive activities huge budget line, no. Just come with us, with our Dr. Jovana Todorovic, and see how we have amazing time walking around Ada Lake and exercising moderate physical activity, being at the same time in the world of entertainment and health, because we are deeply convinced working in global health that we must cut loneliness, we must cut social inclusion, but we must be happy, and because that is the way, together with wisdom, how we can improve health, not only our, but other people. Be happy, entertain, and be with us. And we have one more question. Should we prioritize health issues versus climate change, or are they connected issues?
Do you want to create a poll to everybody answer? Yeah, I can do that.
Do you like to answer, Miloš?
No, I said we can create the poll so everyone in the room can answer.
Okay, please, we will open now, slide the poll. Say yes if you think, or no, that climate and health are not connected. And never forget that humans are the only species who are destroying their own natural environment. The only species at the planet Earth, unfortunately.
Just a second.
The one thing that I find important to mention, also to complement my answer to the first question, what can you do, taking into account the field that we covered through these presentations, and I missed to mention the one. So addressing the vaccine hesitancy, that is the very important area that you can provide your help. So being a very good champions in advocating vaccination as one of the main
achievements of modern civilization
yeah.
and fighting
Sure.
that approach for extreme hazards. There is along these today's areas. Yeah. Thank you.
We are on Sonic thinking the same, of course. Thank you so much. And now, on behalf of Belgrade University and also our Circle U network, we would like slowly to conclude this event, but only for this very moment and in this classroom. We are inviting you to join us in a light lunch here in our club of students and professors, and we can further discuss. Join us. Thank you for being with us.
Did you vote yes? You voted yes?
That's it. Thank you.
Thank you.